Hello everyone, welcome to Raw Online. I'm Dr. Abhinaya. I'm a consultant pediatrician. So in Nelson-based pediatric teaching in the chapter discussion of nephrology, our next topic of discussion will be on renal replacement therapy. So before going on to what are the modalities of various modalities under RRT, we will see first what are the indications. I'm sure by now you would have all gone through the acute kidney injury presentation and chronic kidney disease. So in those presentations also a brief discussion on RRT I have done. Okay, so by now you will know what are the indications for RRT. Anyways, we will just go through shortly. So for uremia, you will do RRT, isn't it? So symptomatic uremia, like there is uremic encephalopathy, uremic pericarditis, uremic GI bleeding. Next, for fluid overload. So for AKI, severe AKI, what happens? There will be fluid overload. So fluid overload can present as respiratory failure, CCF or hypertension. Next is for our electrolyte disturbances or metabolic disturbances. Severe or refractory hyperkalemia, severe hypernatremia, severe metabolic acidosis, all those conditions will come under metabolic disturbances. So if you want to write for the exam, start with the indications for renal replacement therapy and then move on to write down what are the common modalities. So for renal conditions, you know. For non-renal conditions, whenever we encounter a child with poisoning also, we consider hemodialysis, isn't it? So some non-renal conditions we will see. Number one will be toxins. So to remove the toxins like lithium, methanol, salicylates, we do dialysis. Next one, sepsis and septic shock. So refractory septic shock with hemodynamic instability, with multi-organ dysfunction, yes, RRT is done. Why for sepsis or septic shock with MODS is the cytokines, all your inflammatory mediators. So these are middle molecules we say. I will tell you what are the small, middle and large molecules in a while. But all the inflammatory mediators are coming under the middle molecules. Yeah. So dialysis will play a role in removing all the cytokines and inflammatory mediators. So sepsis, shock, MODS we can consider. In fulminant hepatic failure, sometimes yes, we do dialysis. And finally, severe pancreatitis. So what are the different modalities which comes under renal replacement therapy? Number one, which we do in our wards, acute peritoneal dialysis. Yes, you would have all done peritoneal dialysis. Yes, I am sure. So acute PD. Number two will be intermittent hemodialysis. We know continuous dialysis, intermittent dialysis. That much you will know by now. Yes, as a postgraduate. So intermittent hemodialysis is one modality. Number three, prolonged intermittent RRT or SLED. So this is a slow dialysis. So that is SLED, and prolonged intermittent RRT is otherwise known as PIRRT. In this discussion, we are going to talk about intermittent hemodialysis and our continuous renal replacement therapy, that is CRRT. Very few points about PD. I am not going to discuss about SLED here. So what are the principles of RRT? There are four principles which we will see, and which are the basic principles by which fluids, by which the water, by which the solutes, the molecules are going to get filtered. Okay. So what are the four principles? Number one, so number 1, 2, 3, 4, any randomly we can see, but from the simplest we will start. Okay. Number 1 is ultrafiltration. Ultrafiltration means the water or the fluid will get filtered. That is ultrafiltration. Number 2, convection. Convection is very popular. That is what is used in most modalities, where both the fluid and both the molecules, so medium and large molecules, will get filtered. Number 3 is diffusion. Diffusion is what? Diffusion is a principle that is used in peritoneal dialysis. Number 4 is adsorption. There is a semi-permeable membrane. All the molecules will get adsorbed over here. I will discuss in detail. Okay, don't worry. Just the principles of RRT. You know what are the indications of RRT. What are the modalities? You know. What is the principle behind renal replacement therapy? How was dialysis invented and what was it behind? So these are some of the basic principles. Okay. So now about each principle we will discuss further. Number 1, simplest one, ultrafiltration. You only want, if it is a fluid overload state, I just want the fluid alone to get removed. I don't have metabolic disturbances, electrolytes and all is normal in this child. So only the excess fluid I want to remove. That time I will opt for ultrafiltration. What is ultrafiltration? Yeah, okay. So ultrafiltration is blood from the patient goes into the dialyzer and here is the membrane. Okay. So from blood, water is alone removed. The fluid alone is removed without the solutes. So this is the ultrafiltration. So when do you want ultrafiltration? Only when I want the fluid to get removed during the fluid overload state. So it is from a high pressure to a low pressure, the fluid will move. So the pressure will push the fluid through the filter. Sometimes if the pressure is not enough, you can also apply a suction that will pull the fluid to the other side of the filter. And the rate of ultrafiltration will depend on the pressure. So when you do a suction or when you send the fluid from a high pressure to a low pressure, the rate of ultrafiltration will be high. So higher pressures, so it depends on the pressure and depend on the flow rate. High pressure, faster flow will increase the rate of ultrafiltration. Low pressure, slow fluid rate will decrease the rate of ultrafiltration. Very, very simple modality. Okay, it is for water or fluid overload. That's all. Next one is our popular convection. Convection is you are removing the solutes. Okay. So when the water actually moves from the high pressure to the low pressure, it will drag the solutes. So this is called as the solvent drag. So the movement of solutes through the membrane by the force of water. The movement of solute through a membrane by the force of water is called as the solvent drag. So convection will be able to remove the large molecules like your protein and middle molecules like all your sepsis, the inflammatory mediators. Okay. So it is able to filter or move the large and middle molecules. Okay, if the movement is fast enough. What we do in renal replacement therapy is to improve. Okay. So in renal replacement therapy, what we do to maximize this filtration, we add a replacement fluid. Replacement fluid is nothing but a crystalloids, okay, which will be administered at a very fast rate once the blood enters the dialyzer machine or just the blood is leaving the filter. Okay. So just look at the diagram here. So blood from the patient goes in the dialyzer machine inside the unit and you give a replacement solution which is ideally a crystalloid. So it is administered at such a faster rate along with the blood, along with the replacement solution. Fluid is also getting removed. All the solutes, the large molecules, the middle size molecules are also getting filtered here. So this is convection. Okay. What you should remember is 4 principles you know. In ultrafiltration, there is only fluid, only volume overload state you can use. That is filtration. Convection, you can use it to remove all your solutes. How the solutes are going? Because you add a replacement solution which is here. You add a replacement solution. Such a faster rate the replacement solution will be moving across the membrane. Because of the replacement solution and the speed, all our solutes, both the large and the middle molecules will get filtered. This much if you remember for each of these modality, it is more than enough. Next one is diffusion. Diffusion, typically it is our peritoneal dialysis. Okay, you are giving a fluid, you are giving a dialysate fluid which is glucose based and you give a dwelling time. It dwells inside the peritoneal cavity and when you, through the catheter, when you remove the fluid, all the solids will come out. So it is nothing but from a high concentration to a low concentration gradient. If you establish a gradient between high concentration and a low concentration, the solutes will move. So that is diffusion. So the solute moves across a concentration gradient. So for the diffusion to occur, you have to give a fluid which is the dialysate fluid. So the dialysate fluid, so this is blood which is coming from the patient, it goes into the dialyzer machine. This is your filter. In the other side, you have a dialysate fluid. Dialysate fluid is basically low concentration fluid. So from high concentration to low concentration, the solutes will move. So this is very simple, diffusion, that's all. Okay, not much of complication here. Just remember the term, we use a dialysate fluid to enhance or to facilitate the diffusion. Next one is adsorption. Adsorption is nothing, you have a filter here. All the solutes will get absorbed on the filter. It is not actually moving from high to low concentration, but it's just going and getting stuck. That's all. Okay. So this is nothing. This is like molecular adherence. Okay. So the molecular adherence takes place to the surface or to the interior of the membrane. But when there are so many solutes or high levels of solutes, when they go and get stuck in the membrane, what can cause? All the filter will get clogged and then it will become ineffective. So adsorption will also remove the solutes, because the solutes will go and absorb to the membrane, or it will just go stuck or cling to the membrane. But the disadvantage is the filter will get clogged and become ineffective. That's all. So I was talking about small, middle and large molecules. So small molecules are basically your electrolytes: sodium, phosphorus, potassium and urea. Middle molecules will be your glucose, uric acid, creatinine, aluminium, vitamins and all our inflammatory mediators. Large molecules will be proteins. Okay. So now we have discussed about the various types of molecules based on the size. We will move on to the various RRT techniques. So in the initial slide also I was talking about intermittent and continuous. In intermittent we have two modalities. One is intermittent hemodialysis and another one is ultrafiltration. Intermittent ultrafiltration or isolated ultrafiltration. Continuous we have four different modalities. Here in continuous, first modality is here in the bottom most you see slow continuous ultrafiltration. Here only the fluid overload state. Only I want filtration, ultrafiltration alone. I am not aiming at solutes. That is a scuff state. Next, continuous veno-venous hemofiltration. So blood is getting filtered. Here hemodialysis, we are using the technique of dialysis, that is diffusion. Finally, both I want dialysis also, I want diffusion also, I want filtration also. Then I use continuous veno-venous hemodiafiltration. So this is continuous. Hybrid is you use a technique of both intermittent and continuous in a same patient. Okay. So slow daily dialysis you do, or slow daily dialysis with filtration you do. So that is SLED technique. We are not going to discuss here now. Okay. So we will start with the continuous RRT techniques. Yeah, before that, so just what I mentioned already. Only when you need a filtration, that is for fluid overload state, you go for scuff, that is slow continuous ultrafiltration, or veno-venous hemofiltration. When you only want solutes, then you go for hemodialysis. When you want both solutes and fluid to be removed, then you go for continuous veno-venous hemodiafiltration. Right? I hope you got the point. Yeah. So now we will talk about scuff here and then move on to the other continuous renal replacement therapies. Okay. So scuff is here it is a it uses high flux membranes, which means a very rapid fluid overload state can be corrected here depending on the flow rates. This is only, our objective here is only volume control. It is not suitable for solute clearance. Blood flow maximum up to 200 ml per minute. So rapid flow can be achieved here also. Here from the patient, from the body, patient's blood is going through the dialyzer. Here through the filtration, all the excess fluid is removed to the effluent bag and then it goes back to the patient. Okay. So the ultrafiltration rate will be up to 6 to 8 ml per minute. Slowest rate will be 2 ml per minute. Okay. That is scuff. Continuous veno-venous hemofiltration. Okay. So here what we use is convection is used here. So from here, from the patient, the blood flows. In convection, what happens in convection? My aim is to remove the solutes, both large and middle molecules can be removed. So for that what I use is, I use a replacement fluid, which is ideally a crystal oil. So as soon as the blood enters the filter here, so the blood is entering the filter, immediately I start my replacement fluid, that also goes at such a faster rate, and the filter, the convection happens. So the waste materials, all the solutes are getting collected in the effluent bag. So once the filtration is done, it goes back to the patient's system. So this is convection used here. So in hemodialysis, diffusion is used. So here again access from the patient, blood is coming. Diffusion means we use a dialysate fluid. Dialysate fluid is used here. The blue bag is the dialysate fluid. So that is used here. So the blood passes through the filter, dialysate is used, all the effluent and dialysate is collected here and then the blood is returned. So small and medium molecules will be removed through diffusion. And hemodiafiltration is combination of everything, both the convection and diffusion. So here we use a replacement fluid and also we use a dialysate fluid. So it is a combination where fluid is removed, small molecule is removed, medium and large molecule is removed through convection. So the most effective therapy will be hemodiafiltration, HDF. This is about intermittent therapy. Intermittent therapy, what happens in intermittent dialysis? So this is relatively an inexpensive. When we subject the patient to a continuous hemodialysis or filtration, it is going to be an expensive modality, and in intermittent technique for the patient you allow that the dialysis or the filtration happens only for a specified amount of time, say for 3 to 6 hours or a maximum up to 8 hours. So it depends on the patient's condition. So flexible timing is there. In intermittent dialysis also rapidly you can correct the fluid overload. So that is an advantage. The dialysable drugs can be removed, all your electrolyte abnormalities and acidosis can be rapidly corrected, and for continuous renal replacement therapy only we should use the anticoagulant. In here in the intermittent renal replacement therapy we do not use anticoagulation. Okay, so this slide is about advantages of intermittent renal replacement therapy. So what are the disadvantages? Hypotension can occur. Hypotension can occur both in intermittent and continuous renal replacement therapy, that is one. Cerebral edema, in case the solutes are not able to remove properly, then it can cause cerebral edema. Another disadvantage will be you have only limited duration. For a day, for 24 hours, you do 6 to 8 hours like that. So limited duration. So the therapy itself will be limited, and renal injury or ischemia can also happen. Gut or coronary ischemia can also happen during your intermittent renal replacement therapy. Coming to the advantages of continuous renal replacement therapy. So continuous renal replacement therapy is better renal recovery. So continuously dialysis is happening, right? So better hemodynamic stability when compared to your intermittent one, because intermittent is during those times. So during that 6 to 8 hours hypotension can occur, but here hemodynamic stability is better and predictable volume control. So you know, since the patient is on continuous renal replacement therapy, you know you will have a control over the patient's volume, you will have a control over the patient's biochemistry and stable intracranial pressure. Cerebral edema incidence is less here in continuous renal replacement therapy, and cytokine removals like your for sepsis or MODS, continuous renal replacement therapy is more advantageous. Okay, what are the disadvantages? One is anticoagulation requirements. Number 2 is expense. Number 3, since it is happening in a continuous way, the filter can get clogged because of the adsorption, and because of the anticoagulation there is an increased risk of bleeding. What are the various vascular access for pediatric RRT? It can happen through a subclavian, IJV, femoral or EJV. AV fistulas and AV grafts are more commonly seen in adults. Anticoagulation, initially we start with unfractionated heparin bolus of 50 units per kg. Maintenance is done through 10 units per kg per hour. If in some cases they also go for heparin free, so initially they prime the circuit and then they go for an heparin free, and it's entirely dependent on nephrologists. Complications of renal replacement therapy, just combine both. For intermittent renal replacement therapy, what were the complications? For continuous, what were the complications? Basically, complications are one thing is very easily, because when we do a central venous line, because of that there can be infections. There definitely will be, even in a continuous veno-venous hemodialysis or filtration, you have a control over the fluid overload, but sometimes there can be acid-base imbalance and electrolyte imbalance which is out of our hands. Okay. Bleeding because of heparinization, hypothermia can be there, and inappropriate dosage of medicines sometimes can be an error from our side. Okay. So peritoneal dialysis, of course, we have all done in our wards during our post-graduation, and most cost effective of all the renal replacement therapy and more simplest form. Simplest being more physiological form also. So that we have to emphasize here. Okay. So most physiological form of dialysis, and continuously you can do PD. So that is an advantage, and percutaneously you can insert the catheter. That is another advantage for peritoneal dialysis. Less inflammation. You do not want to give any anticoagulation like your continuous renal replacement. We need to give a continuous anticoagulation should be there. Here anticoagulation is not needed, and hypotension will be avoided. PD is very effective, not only just for the fluids but for the solute clearance also, in that especially middle molecule clearance. So you have a septic child hemodynamically unstable, immediately we can go for peritoneal dialysis. Extreme hypernatremia, acidosis, we can start. And the another advantage, we don't want a vascular access like an IJV or subclavian vein, which needs an expertise. So that is another advantage, and it does not cause alterations in the ICP. So even in a case of raised ICP, peritoneal dialysis can safely be initiated. So disadvantage will be solute removal is the advantage, but the disadvantage will be the fluid removal will be very unpredictable in a peritoneal dialysis. And since you are inserting a PD catheter intra-abdominally into the peritoneal cavity, the risk of peritonitis is there. So that is one disadvantage, and very vigilant monitoring is needed. So 24/7 nursing care, and the pediatrician has to be present, or you need a nephrologist on call. So all these, like the logistics issues there for peritoneal dialysis, and sometimes the dialysis catheter can get blocked, so obstruction or leak from the PD catheter. All this drug clearance again is a query. So for a hemodynamically unstable septic child raised ICP, PD can be initiated even in the wards. That is the advantage, but the fluid removal and the solute removal or the drugs removal especially can be very unpredictable. One more is hyperglycemia, because the dialysate fluid that we are going to insert, that we are going to give inside the cavity, peritoneal cavity, is your glucose based solution. So it will cause hyperglycemia. So for frequent monitoring of random blood sugar is very important. It can cause hypokalemia also. Okay. So far we have talked about renal replacement therapy. So initially this question is asked many a times. I have seen in the question papers of DNB and MD pediatrics. So when you are asked what are the talk about or tell about renal replacement therapy, start with indications. So indications for renal replacement therapy divide into two. So here it will be renal condition, and this branch will be non-renal condition. So write down the indications. Next, how does renal replacement therapy work? What are the 4 principles? So 4 principles: filtration, convection, diffusion, adsorption. So write those 4. Next, what are the intermittent, hybrid and the continuous RRT? We have talked about the 3. So write these 3. And you can draw simple diagrams. So in ultrafiltration, what happens? Only water is removed. Convection, what happens? You are using the replacement fluid. In diffusion, what happens? You are using a dialysate. In adsorption, there is a membrane which will filter. So salient points you can definitely write. And then you start explaining about SCUF, slow continuous ultrafiltration, what happens in CVVH, what happens in CVVHD, and finally CVVHDF. And disadvantages and advantages of both intermittent and continuous you can discuss. Finally, about peritoneal dialysis. I hope I have made it very simplified, because the basic points only I have discussed. When we talk about renal replacement therapy, it gets very complicated beyond one point. So I have stopped here. I hope this is simple and easy to understand. From an MD point of view, if you remember this and you write in your exams and answer this, it is more than enough. Thank you so much everybody for your patient listening.